Good evening, sir. I'm just sharing.
Good evening, Amit sir.
Good evening.
And sir, this is Manas Singh Chauhan, AB Vitalist for Meerut, sir. And
Okay.
on behalf of CIPLA, sir, we are delighted to invite you for the Strengthening Heart Expert Summit, sir. And the topic is MR in heart failure, sir. And on this, sir, we also wants to pay regards to all the expert panelists, Dr. Vimal Nishad, Dr. Anchla Singh, Dr. Shubham Jain, Dr. Mahendra Pal Singh, Dr. Ajay Singh Sikarwar, Dr. Abid Ali Ansari, and Dr. Vijay Kumar Garola, sir. And requesting you all, sir, please put your camera on for this meeting, sir. It's a request, sir. And I just want to share that Dr. Amit Kumar Gupta is taking as a moderator, and he is practicing. He is cardiologist in Kanpur, and he will share his views on MR in heart failure. That's with the theme line of "Jump on the bandwagon," sir. And sir, session is over to you, sir. Amit sir, you can share your views, sir.
Okay. I would request someone to change the slide because I am taking help of my mobile. And so can we? Can someone change?
Yeah, yeah, sir. Yeah, sir.
Okay.
I will take care.
Okay.
I will take care.
Okay.
I will take it.
So, very good evening to all of you. As introduced by Sipla person, means today we are going to discuss about a very important topic, that is the heart failure. And in heart failure, the one of this drug MRA, that is less talked molecule. So we'll be discussing about this molecule. As you all know that in management of heart failure, there is important role of ARNI. Previously, there was ACE inhibitor or ARB. Similarly, there is the role of beta blocker. Now we have got a new drug in form of SGLT2 inhibitor for heart failure. But this molecule, that is the MRA, which is available in form of spironolactone, and another is ipaldione, that is not much talked in the various meets. So we'll be talking, and also we'll be discussing why it is underutilized and what is the means concern during our general practice, the concern related to the side effects like hyperkalemia or means there's anti-progesterone side effects like loss of libido, gynecomastia. These types of side effects are we have read in our pharmacology book. So we'll be discussing what is there in the clinical practice in the real world. And also, the objective will be to create the awareness among physicians to use these MRAs in indicated patients. Means we have got ESC as well as the AHA guidelines for the heart failure. So we'll see what the guidelines have to say. Next, please. Population in developing countries having hospital and is more than 10% people who are under 20 years.
Sir, sorry to interrupt.
Your voice is not audible.
Sir, sorry to interrupt you. Sir, there is a connection issue, sir. Amit sir.
Is it audible now?
Yes, sir.
Yeah,
Audible,
yeah,
sir.
it's fine now.
Okay. Sorry for that problem. As we have seen that as the age is progressing and as there is advancement in the field of cardiology, a lot of patients are living in their 70s and 80s. Even the octogenarians, means after 80s, we are getting. So, due to advancement in the field of cardiology, we are there is the increase in incidence of heart failure because more of patients having congenital heart disease who are dying at early age, but now due to advancement in the surgery, they are able to live at a means a longer life. Similarly, the patient having bypass surgery or angioplasty, they also, with the advancement of technology, they are living long. So the incidence of heart failure is gradually increasing day by day. Similarly, in India, the 1% of population, that 2 million individuals are having a problem of heart failure. The means the 50% population of heart failure. Next, please. The winner has been decided in such a way that we will be having certain questions and we are asking who will
Sir, sorry to interrupt, but again you are not audible.
now it is audible.
Sir, it's fine now.
Okay. I have to keep my mobile close to my lips. Okay. What percent of heart failure patients approach you in NYC stage 2, 3, 4? And how many heart failure patients goes undiagnosed in India at an early stage and why? So, would anyone like to answer this question or shall we discuss them? Okay. So, as you know that heart failure is of two types. That is heart failure with reduced ejection fraction.
Sir, again, sorry to interrupt. Sir, Amit sir, sorry to again interrupt you, but I think that there is a connection, internet connection issue, sir, because your voice is breaking. Maybe, sir, some of the doctors are facing issues that they are unable to listen, sir, your questions and discussion, sir.
So Manas,
Yes,
Manas Nishant here. I would like to again. So ask, please request from Mr. because we have our expert. He can ask to each expert whatever the question they can answer.
okay, sir.
Hello.
Yes, sir.
Shall I continue to change? It will take some time, but for sake of time, I have chosen to start with the mobile. Is it audible or not? Hello.
Sir, now
Sir,
it is audible.
you're audible, but your voice is breaking in between.
Sometimes it's breaking.
Sir, now you are audible.
Is it audible?
Yes, sir,
Hello?
please continue.
Yes,
Yes, sir, it's fine now.
Yeah. Now I think just came out. So what percentage of heart failure patients approach you in the NYHA stage 2, 3, 4? And how many heart failure patient goes undiagnosed in India at an early stage and why? So to answer this question, we would like to say that the heart failure is of two types. One is reduced ejection fraction, where EF is less than 40%. Another is the preserved ejection fraction, where EF is more than 50%. Between 40 to 50%, we have got a mid-range ejection fraction. So if we go with the functional class, the NYHA staging, everyone must be knowing. There is the 4 stages. So if we see how many percentage of patients are coming in the clinical practice, then I would like to say 1/3 of patients comes in stage 2, 1/3 in stage 3, 1/3 in stage 4. There is the equal distribution of the such type of patients. And how many heart failure patient goes undiagnosed in India at an early stage? We are not able to catch this problem at an early stage because in a clinical practice where we are having a busy OPD, we are not able to see the subtle signs like the RAVE, JVP or some LV-S3 or S4. So these type of findings generally we miss. And if we are not having the facility of echo or this BNP biomarker, though sometimes we can miss this heart failure diagnosis. So it's quite common heart failure patients are often missed at an early stage. The second question is, what are the diagnostic and prognostic tools which we can use for heart failure patient? As I have told that for making the diagnosis of heart failure, the best modality is the echocardiography, where you can see the anatomy of the heart, where you can study the functional abnormality, where there is the diastolic abnormality of different grades are there. And for prognosis also, we can take help of this echocardiography. It helps in guiding us the prognosis. Suppose if the patient ejection fraction is on. Hello.
Yes, sir. Yes.
Sorry to say, but in front of my hospital, there is a metro work is going. So there must be some loud noise is coming.
No, no. Voice is
No,
clear, sir.
Okay.
no issue, sir. Your
One
voice is clear.
request to you, sir.
I think my voice would be clear now, means because
Yeah,
I
yeah,
came out.
yeah.
Okay.
Yeah, yeah.
Yes, sir. Yes, sir. It's fine.
Okay.
Sir,
Okay.
you can,
For
you
prognosis,
can ask these questions to our experts, sir.
yeah, for prognosis, means echocardiography help us in saying if the patient is having, say, a simple valvular heart disease in form of mitral stenosis and is coming to hospital repeatedly in form of heart failure. So the prognosis there is good. You can open the valve, patient can get rid of his heart failure. But similarly, if the patient is having ischemic cardiomyopathy with, say, ejection fraction of around 20 or 25%, there the prognosis is very bad. So this help us in deciding this type of patient we are dealing, and accordingly we can prognosticate the patient on the basis of echocardiographic information. Similarly, if we are not having the facility of echocardiography, we can help a simple biomarker test like TROPI. We have got now the biomarker in form of NT-proBNP and BNP for heart failure. These biomarkers help us in prognosis the disease. If the biomarker level is too high, then the patient prognosis is more worse as compared to patient where the biomarker is not so raised. So these two modality, I think, help us in diagnosing and prognosing the patients of heart failure. Next. This is the 2021 update to the 2017 ACC expert consensus decision pathway for optimization of heart failure treatment. Here there is a cautions should be exercised when MRA is used. Everyone must be knowing that MRA should not be used in patients where the potassium level is more than 5 or where there is a severe renal impairment, where GFR is less than 30 or creatinine value is more than 2.5 in males and more than 2 in females. So these parameters we have to check before starting the epalerenone or the spironolactone. Next, please. Are these parameters, potassium level, creatinine, and eGFR, tested before and after initiating MRA? Definitely, we have to check the potassium level, creatinine, and eGFR before starting, and also after a week when we have started the MRA. Hello.
So, sir, this question can be asked either to Dr. Vijay, Dr. Avid is there, Archana, Dr. MP, Dr. Demal. We make their video on, and to answer this, because it's a ad board meeting. It's not like a Bombay program. Thank you.
Hello. Hello. Hello, is there some problem?
No, no, sir. No problem, sir. Actually, these questions are for our expert. Sir, you can take a name of any expert.
Means I have not been told by you person means how we have to move in this webinar. Whether we have to answer or somebody else will be answering these questions.
Somebody else, sir.
Sir, these questions will be answered by the expert, sir, not by you.
Sir, I suppose you have to ask for the opinions of other panelists in these questions.
So I think those who want to answer this question, they are most welcome. I was not aware how to carry this meeting. I was not been briefed how this meeting will be proceeded. Okay.
Sir,
I would request my seniors and my other colleagues who have joined this meeting. They are being most welcome to answer these questions. Yeah.
These type parameters should be tested before, yes.
Yes, so definitely should be
Definitely.
tested, but practically, do we test it every time? Like sometimes we give spironolactone for a very short period of time for things like generalized anasarca or resistant hypertension. So do we actually test this every time in general practice?
Yes, every time we test these general parameters like potassium or creatinine levels. Just because of these, we are titrating the dose of MRAs, other drugs,
Okay.
OHAs. That's why we are testing.
Okay, sir.
And just before the test starting and after 7 days, we are again testing the same values. And 1 month after the starting the dose of MRAs to titrate to according to patients. According to patient GDMT, we are titrating the doses for him. What is suitable for him? So like someone is on 25 mg spironolactone, someone is on 50, and someone
Yes,
is
sir.
tolerating 100 mg of spironolactone.
Yes,
That's
sir.
why we are testing. It's before starting at 7 days and one month of therapy. Then 6 months or 1 year we can test.
Okay. So we should always keep this in mind.
Yeah.
Thank you. Thank you.
Yeah. Nicely explained. Means, can we move for next question?
Yes, sir, please.
Yes. So heart failure guidelines recommendation for MRA according to ESC 2021. If we go for patient, MRA is recommended to reduce the risk of heart failure, hospitalization, and death as a class 1 recommendation. But for mid-range ejection fraction, the same indication is there, but the level of class is slightly on. It's class 2B. So similarly with the FF, we are not having enough data, but whatever data is there, it's convincing. In that patients also we can use MRA. So next slide, please. This is the overview. Although it's a busy slide, we can tell you in short about the management of heart failure, HFrEF patients. To reduce the mortality, we have got options in form of ARNI, beta blocker, MRA, and SGLT2 inhibitors. For symptomatic relief, when patient comes to your emergency room, you have to use the diuretic and take support of either NTG or other inotropes when patient is having a reduced ejection fraction. If patient is having a specific indication on ECG, that is, there is a left bundle branch block with a wide QRS rhythm, you can also take help of these devices like CRT or ICD. For other indications, especially in the blacks people, where we can also take help of isosorbide, dinitrate, and hydralazine combination that has also shown to have a good outcome in patients of heart failure. If we are not able to achieve a heart rate of less than 70 with the guideline directed beta blocker dose, so in such cases we can take help of ivabradine. Similarly, if patient is having iron deficiency, you have to give the iron supplement. If patient is having say other mechanical problem is there, some valvular heart disease is there, or some ischemic heart disease is there, you have to surgically correct that thing. And I think with this we can give the guideline therapy, and accordingly we can titrate the dosage slowly and follow. We can call patient in the OPD, and slowly we can up titrate the doses. Next slide, please. So now we have reached for the fourth question. In what percentage of patients you use MRA for heart failure management?
90%, almost 90 to 95%. Yeah, using
90%, yeah.
Yeah.
Also opinion can be shared by rest panelists also. Like Dr. MP we have, Dr. Anchila we have, Dr. Vimal, Dr.
Sir, my question to you,
Which is the preferred MRA you used in the patient of heart failure? Or on what basis you decide that whether aldosterone or aldosterone should be used?
I think now we are living in this era where we can use epinephrine because it has got more selectivity over this aldosterone receptor. It has got spironolactone has got lot of testosterone and anti-progesterone side effects, where we can see loss of libido and gynecomastia. That problems are there. But when we compare epinephrine, it is 1,000 to say 10,000 more selective for this aldosterone receptor.
Okay. But is there any preferred dose to start with and slowly titration of dose?
Yeah, we have to start with a lower dose, that is 25 mg, and slowly we have to up titrate dose. Means, we can go for 50 mg, or some cases we can go up to 100 mg.
Okay.
I think we can go for next question. When do you consider starting MRA in patients with heart failure along with ACE inhibitor or ARB and beta blocker? I
As
think
soon
this
as
is very
possible, sir.
important question.
As soon as possible, as lab reports comes, we find the serum creatinine and potassium level is within a normal limit, we start MRAs. As because of it is having an advantage of to prevent remodeling. That's why we are using it as soon as possible. As it's the fourth one of the four pillar of heart failure management, we have to start as early as possible. Otherwise, there is no remodeling advantage.
Yeah. Is there any another comment from another expert? I think very well explained by the previous speaker. But I would like to add one thing. If we go by the guideline, there is specific indication when we have to start MRA. Patients who are symptomatic even after starting this ARNI, beta blocker, and SGLT2 inhibitor, and patient having ejection fraction less than 35%, in those cases we can start with MRA, where the creatinine, potassium, they are on recommended side. So these are what guidelines this ACC and ESC has to say. Yeah. Next slide, please. This is the aldosterone escape in congestive heart failure, where the importance of timely initiation of mineralocorticoid receptor antagonists on the risk of mortality in patients of heart failure has been explained. Use MRA as early as possible on top of treatment, including ACE inhibitor or ARB and beta blocker, preferably at the discharge after an episode of decompensated heart failure. What is the aldosterone escape? It is following an acute fall in aldosterone in response to administration of ACE inhibitor. The level of aldosterone rises again, and indeed it returns to baseline in almost all patients of heart failure. This is the aldosterone escape phenomena. And even when ACE inhibitor is given in combination with an ARB, aldosterone levels remain uncontrolled, and aldosterone escape might promote the release of angiotensin II via positive feedback loop that stimulates the ACE in the vasculature. As you know that activation of ACE is deleterious in pathophysiology of the heart failure. So there is some ACE activity is going on in vasculature that is not going to benefit patients. The progressive escape of aldosterone are thought to contribute to the ACE inhibitor resistance, whereby the effect of ACE inhibitor becomes blunted and the beneficial effects on the mortality decreases over time, whereas MRA are able to antagonize the deleterious effect of aldosterone, resulting in the beneficial effect on patient mortality. As well explained by our previous speaker that it should be started, but guidelines have added certain clause which we have also to follow. Next slide, please. This is the improvement in the systolic function. It has been taken from a landmark trial. I think this is there are the two means the landmark trial done with the epalerenone. One is Ephesus, one was Emphasis. Ephesus was done in patients of post-MI setup where the ejection fraction was less than 40%, and Emphasis was done for patients who are having class 1 to class 2 heart failure. There in both studies, they have shown to have a very good result on the mortality and morbidity. I think this is some meta-analysis or something that means I am not able to get this thing. But we have to remember the two important trials for epalerenone, that is the Ephesus and Emphasis. Next. So now the sixth question is, when do you prefer using epalerenone and spironolactone? Any specific patient profile? Now the question is for the audience. When do you prefer using epalerenone and spironolactone?
So I would request to rest expert who have not spoken yet. They can make their video on and they can share their opinion.
What about primary hyperaldosteronism? Do we use it there?
Yes, we do use a spironolactone for primary hyperaldosteronism, but in situations when it is a resistant hypertension in a young patient, and in cases of one of the cause can be primary hyperaldosteronism, in such situation we do use spironolactone.
So we can combine the both.
Not exactly combined. We can use any one of these. Spironolactone has a more potency as compared to eplerenone, but has a large eplerenone has a lesser side effects of like gynecomastia. And secondly, special profile can be in a premenstrual female, as MRAs have a progesterone-like effect, so that can cause a more menstrual bleeding. So in that cases, eplerenone is preferred over the spironolactone.
I would like to say that epalerenone is always favored over spironolactone because it is free of all the side effects which the spironolactone has got. Most of the unbearable side effects, while it is having all the benefits which spironolactone was giving. So epalerenone is always preferred over the spironolactone. You have to use any one of them, not together. And for the primary hyperaldosteronism, this can be given as a part of medical therapy, but the primary treatment, as you know, that the cause of primary hyperaldosteronism, definitely the adenomas, all those things, tumor-like thing in the adrenal, that has to be corrected surgically. Yeah. Okay. Shall we move to next slide, please?
Yes, sir.
Yeah. So this is the management of hyperkalemia when we are using the epalerenone or spironolactone in patients of heart failure. I think all of you are aware of the managing hyperkalemia, but we have to remember certain figures that we should not use when we are planning to start epalerenone, and if the potassium level is more than 5, we should not use this drug. And suppose that if the patient is already on this type of drug and the patient potassium is more than 6, then you have to stop these drugs. If patient potassium is between 5.5 to 5.9, you can decrease the dose. If the patient was on the 50 mg spironolactone, you have to make it 25 mg. Similarly, if it was 25 mg, you have to make it alternate day, and after a week, you have to recheck the potassium. If it is more than 6, then you have to definitely stop. Otherwise, you can carry on this. And if patient potassium is between 4 to 5.5, we can no adjustment is required. And if patient potassium is less than 4, then you can increase up to the maximum tolerable dose, which is 50 mg, say for the spironolactone, and for 100 mg for this epalerenone is there. Yeah, I think if there is any query till now, we can answer. Okay, next slide, please. So what is the preferred dose and how is the dose titration carried out in your day-to-day practice?
Preferred dose is 25 milligram once a day. And it should be titrated as once a week, or after 2 weeks, we have to titrate. seeing its lab parameter, we can titrate after 7 days only. Till 7 days,
Yes.
we have to continue 25 mg per day.
On the
Yeah.
basis of potassium levels.
Yeah. Very correct. This is the approach we follow in our day-to-day practice. We have to start at the lower possible dose. We have to check potassium after a week, and slowly we can up titrate the dose. Next slide, please. This is a paper related to MRA-related hyperkalemia. Means in trials, it has been shown that the incidence of hyperkalemia is somewhere between 5 to 10%. And in clinical practice also, we found that if you are not very alert while starting hyperkalemia, while starting this mineralocorticoid antagonist, then we can get incidence of hyperkalemia. But if you are cautious, we have checked the potassium, we have checked the eGFR, then the incidence is not so much. So this is all theoretical, means we can get, but if you are cautious, then you can avoid this problem. Next. So what percentage of heart failure patients on MRA develop hyperkalemia, and do they require discontinuation of treatment? Any expert?
This question we would request to Dr. Abid Ali Ansari. Sir, you can make your video on that if you can share some of it. Thank you.
What percentage of MRAs develop? Sir, 10%, almost 10% approx. 10 to 5 to 10% patient develops hyperkalemia.
Yes. Very
And
correct,
we have to
very
stop
correct.
for 7 days. We have to stop for 7 days.
Yes. Means in last slide, we have seen how to manage the hyperkalemia if patient has been on MRA. We see that if patient potassium is more than 6, then definitely we have to stop. Otherwise, we can decrease the dose or make the dose alternate day, and we can continue, and we have to follow the potassium level. So this is the way how we manage the hyperkalemia when patient is on MRA, and the percentage is very correctly told by our expert panel. Yeah. Next question is, if yes, in how many percentage of patients, and how are these patients managed? I think in last slide we have very well discussed about the management of hyperkalemia when patients on MRA. If there's some query, we can again discuss this thing. If there is no such query, then we can move to the next slide, please.
Yes.
So this is the trial which we are talking, that is the timing of eplerenone initiation and outcomes in patients of heart failure after acute MI complicated by LV systolic dysfunction. This was the FSS trial. This was a landmark trial done for the eplerenone, where the patients of post-MI, where the ejection fraction was less than 40% were taken, and there was remarkable improvement in the mortality and morbidity. That led to the guidelines to give class 1 recommendation for eplerenone in patients of HFrEF. Next slide, please. As you know, before discussing this graph, I would like to say that, as you know, that this aldosterone, it has got a very important role in the heart failure remodeling. There's the activation of aldosterone leads to the fibrosis. These all can lead to the myocardial scarring, and that can lead to all type of arrhythmias, say the atrial or ventricular arrhythmias. That is very deleterious in patients who have developed the MI, because after developing an infarct in the myocardium, you develop a scar. And suppose that a patient gets LV remodeling is going on, and there's more and more fibrosis. So this scar increases, and there's more chance of having this type of tachyarrhythmias. So it has been shown that earlier administration of eplerenone, it improves the outcome when it is started before 7 days or after 7 days. So there's a remarkable improvement in post-MI patients when it is started before 7 days. Next slide, please. In clinical practice, how early are MRA initiated for management of heart failure patients? I think everyone will be means now able to answer this question.
So as early as lab reports.
As early as possible, yes. So in the first week, as the
Yeah.
lab reports would be normal.
Yeah, first we have to start the angiotensin receptor blocker. Then I think at the time of discharge, means before we are planning to discharge patient, means and that time we can start with the MRA, and we can call patient after a week or 10 days, and we have to check the potassium and creatinine level, and accordingly we can up titrate or continue with the same dose. Yes. Next slide, please. Yeah, this is the therapeutic algorithm of class 1 therapy indication for patients of HFrEF. As you all know that as a class 1 indication, we have to start the ARNI, ACE inhibitor, beta blocker, MRA, dapagliflozin and empagliflozin. Now they are well established for management of HFrEF, and loop diuretics for a symptomatic relief. If patient ejection fraction is less than 35 and QRS is less than 130 QRS duration, and the patient if having a recommendation for ICD, means we can put the ICD for a primary prevention of ventricular tachycardia, where in the ejection fraction is 35% less. As a class 2 or class 1 indication, if it is a ischemic cause, then class 1. If it is a non-ischemic cause, then it is class 2A indication. If patient having ejection fraction more than 35%, so no device is recommended, we have to continue with the medical management. And suppose that if patient is in sinus rhythm, ejection fraction less than 35%, and there is a wide QRS, then you can think of putting either a CRT-D or a CRT-P for as a class 1 and a class 2 indications. If there is a wider complex QRS, then it is the class 1 indication, but it has got a more stronger indication where the QRS is more than 150. But if the QRS is between 130, 149, then as a class 2 indication, we can put the CRT-D in such type of patients. Next slide, please. So I think this is the last questions. At what stage of heart failure, diuretics and MRA both are needed? Anyone would like to answer this question? I think when patient presents in an acute decompensated phase, there you have to give the IV diuretics. Once patient has been settled, patient shifted to the ward or room, then you can start the combination of diuretic and MRA. Means you, after checking the potassium and creatinine value. And what is the preferred choice of therapy? Definitely the preferred choice would be a torsemide and ipaldenone combination, as we have already discussed. Next slide, please. Sorry, this is, I think, the last for all panel members. This question is from the CIPLA side. In your clinical practice, any other indication apart from heart failure where MRA can be used?
Yes, BP, stroke, cirrhosis patient.
Resistant hypertension, cirrhosis.
Yeah, definitely.
Sometimes we can use.
Yeah. In even
chronic liver disease patient, we are using spironolactone up to 200.
Yes. Very correct. And to add this indication, we are also using the patients who are having atrial or ventricular arrhythmias also, where we can use this MRA. And very well said by all the expert panels. These are other indications from heart failure where MRA can be used. And the last question is, what scientific initiative would you suggest to CIPLA for increasing the awareness of MRA amongst our practitioners? Dr. MP, would you like to answer this question?
So there should be frequent CMEs and symposium regarding the benefits of these MRI in patient management of heart failure. Will certainly improve the use of these MRI in patient of heart failure. And that's all, I think.
Yeah. Any closing remarks from Cipla people? Yeah.
Sir, thanks for sharing your valuable views, and thanks for the participants for sharing, attending this meeting, sir. And thanks for Dr. MP Singh for the suggestion for the CIPLA for the awareness among the consultant physicians, and we will acknowledge the same. And thanks for the active participation of Dr. Shubham, Dr. Abid, and Dr. Ajay, sir. And also and last, and I want to thank to Dr. Amit for sharing your valuable comments on the role of MRA in heart failure management, sir. And thanks for joining this session, sir.
Thank you.
Okay. Thank you, all of you. Thank you. Thank you.
Thank
Bye.
you very much.
Thank you, sir. Thank you very much.
Thank you.
Thank you, sir. Sir, we will conduct this type of event in every quarter so that we can share the knowledge to our consultant physician for the MRA and heart failure. Because, sir, MRA and heart failure is, I think, very missing part in our consultant level. So we do this type of scientific engagement in every quarter with you, sir.
Okay. Okay. Okay.
Okay, so thank you, sir. Thank you for giving a valuable time to our organization for the awareness. Thank you, Mr.
So are we done?
Okay. Yeah. Thank you very much.
Hello, ma'am. Can you conclude the meeting?
Yes, sir.
Hello? Yeah. Meeting is over, so you can conclude.
And thanks, Anshula, ma'am. Thanks also. And thanks, Anshula.